Welcome to the Pain Science Podcast, where we discuss science-backed ways to treat chronic pain. I'm your host, Dr. Joe Tatta, a licensed physical therapist and founder of the Integrative Pain Science Institute, where we train practitioners in whole-person pain care. This podcast also serves as a public health campaign to support those living with chronic pain. This podcast is for informational purposes only and not intended to be a substitute for professional medical advice. Hi there, and welcome to this week's episode of the Pain Science Podcast. I am your host, Dr. Joe Tatta. My guest today is Dr. Damian Keter, a physical therapist, educator, and clinical researcher who's doing some really important work at the intersection of pain science and manual therapy. Damien holds national teaching and leadership positions across multiple professional associations and is a co-investigator on a National Institutes of Health grant specifically investigating manual therapy treatment mechanisms. Clinically, he's a board-certified orthopedic clinical specialist with additional certifications in pain rehabilitation. Here's what I find most impressive. Since launching his research agenda in 2022, which is just 4 years ago, he's authored more than 20 peer-reviewed publications, which have been cited over 130 times. That includes his most recent paper, which is a review on manual therapy treatment mechanisms, which was published in 2025. His research zones in on something that really matters deeply to us as clinicians. Why do patients respond so differently to manual therapy? What's actually happening mechanistically when we treat using manual therapy? How we're teaching manual therapy in schools and beyond, and how pain science is reshaping the way we understand it all. We'll review that and more on today's episode. Without further ado, let's begin and let's meet Dr. Damian Keter. Hi there, Damien. Thanks for joining me this week on the podcast.
Absolutely. Thanks for having me. I'm very excited to be here.
I'm looking forward to our conversation. I know that people are as well, because I think people are looking forward to this conversation because you're the one that's going to tie together manual therapy mechanisms along with pain relief and pain science for people. And I think just the marriage of those two or three things is wonderful. Kind of in our big area of pain science we have now with so much going on. Tell me how you became interested in kind of really focusing on the mechanisms of manual therapy, which is so important to us as physical and other physical medicine rehabilitation therapists.
Absolutely. Thank you. And I think my journey to get here has been kind of interesting. When I came out of school, I was kind of torn between two worlds. I really enjoyed, the pain neuroscience education, or now, pain science stuff. I took a lot of coursework, postgraduate coursework in this, kind of diving deeper into that world. And what we were seeing at the time, as you well know, right, is we saw this shift that was already occurring away from pathoanatomical stuff that must be causing pain towards more of this wholesome biopsychosocial model, saying, there's neuroimmune stuff, there's all of this stuff that contributes to this pain experience, and it's more complex than just this one pathoanatomical thing. At the same time, I was congruently doing a lot of manual therapy training, a lot of guru-based stuff, a lot of kind of dabbling, very eclectic type of manual therapy training. And similarly, they were kind of going through the same conundrum. They were going through this conundrum of, we thought that there was pathoanatomical stuff that we were changing with manual therapies. And now that was being debunked and we were seeing that wasn't necessarily, what was actually happening, it was kind of this, well, then what is? Now, the interesting thing is pain science was smart enough to say, okay, there must be other stuff we need to dive into. Whereas manual therapy kind of was in this conundrum of them saying, well, if it's not this, then throw it in the trash can, because we should, we just shouldn't use it. And so there's kind of this trend towards, well, we should just forget about this then, or, if it's not realigning the spine, we shouldn't be using these techniques. Well, that's where my interest kind of said, well, let's pump the brakes here a little bit, right? Can we figure out what some of these puzzle pieces are that are occurring? And then kind of see, is it this same complex picture that's happening with this individual and this individual patient that's causing that treatment response? And so that's where the mechanistic interest came in, is really, kind of looking at those puzzle pieces, looking at those mechanisms that happen when we put our hands on patients, when we use different techniques. And then, hopefully in the future, starting to look at which of these mechanisms actually allow the response to outcome, whether it's a decrease in pain or the patients that see an increase in pain. We want to know why we're seeing some of those things, right? So that's kind of what led me to that path.
Tell me about some of the manual therapy approaches you've studied in the past. I mean, it's common for physical therapists to study, I would think, at least 2 to 3 different schools and start to integrate them into practice.
Yeah, so I think the one that I really enjoyed, or a couple of them that I really enjoyed because they're based on patient response models. To kind of look at how the patients responded to treatments. We're looking at some of the McKenzie trainings, some of the Maitland trainings, some of the Mulligan trainings. A lot of these again guru-based trainings. But what I liked about them is, the technique was based on the patient's response in front of me. So basically, whatever their body told me they needed was kind of where we were going with. This kind of differs from some of the other schools of thought that at the time, and hopefully they've moved away from these models, were kind of, hey, I can find that segment that needs to be mobilized because I have magic hands and I can feel this stuff. And therefore, I'm going to pick which technique is appropriate for you without you being involved in that decision. And this is where, that kind of person-centered aspect of it, that idea of the patient's response should guide things, is actually what led to my PhD work, which looked at this idea that we see a lot of different responses to similar techniques. And so the response is often more patient driven than it is technique driven. And so, those were some of the techniques or some of the kind of manual therapy trainings that I went through.
So I want to start to talk about some of the work you've done. There's a great article that you published in Plus One. It's called Mechanisms of Manual Therapy, a living review of systematic, narrative, and scoping reviews. Lots of great information there for people. You can obviously Google that and find that online. I want to talk about the mechanisms, but before we go into those mechanisms, you have a great graphic in there as well that people can look at. What are the things that we should start to um, let's say, move away from or be very critical in our thinking about terminology around how manual therapy works?
Well, I think there's a lot we don't know. And then, hopefully get an opportunity today to talk about what we found specifically and kind of where some of those gaps were. But, we don't have a clear picture of exactly what is and isn't happening anymore. But, I think at this point, we know that it's not clear. And so we should not be painting clear pictures for patients, meaning I should not be telling a patient, I'm realigning this. I should also not be telling patients, even outside of the biomechanical domain, I shouldn't be telling patients that because I'm able to change their neuroimmune system, that I'm able to treat a viral infection, right, with manual therapy techniques. And so it's important for us to understand that we know that some of these things are happening, but we don't necessarily know which ones matter and how big of an effect is coming from each right now. I think as far as terminology goes, one of the other major areas that needed cleaned up was figuring out what the term mechanism even means. And this was actually really interesting because this term is thrown around very frequently. I hear it often in clinical practice and research where people throw around the term mechanism, and no one really had an idea of what it actually meant. And so Dr. Chad Cook out of Duke actually led a paper beginning of 2025 where we took a group of individuals, physical therapists, chiropractors, psychologists, basic scientists, and we all came up with a couple definitions to outline what mechanisms are and what treatment mechanisms are. And so what we came up with is that mechanisms are the molecular, cellular, and physiological processes or pathways contributing to either disease development, treatment, action, or pain. Okay, so they're kind of these puzzle pieces, these neurophysiological cellular things that are happening that contribute to things like the pain experience, or that contribute to things like response to an intervention, whether it's manual therapy or anything else. Treatment mechanisms, more specifically, we outlined as the underlying process or pathway through which a specific treatment process affects the body, affects the system itself. And so this is looking at what's that stuff, as I mentioned earlier, what's all that stuff that happens in the body when a treatment is applied, in this case, manual therapy. And so, I think as we're putting together these puzzle pieces, as we're kind of putting together some of these ideas, we need to have a very clear understanding of what some of these terms mean. Because again, if you look in the literature, these things are thrown around, all over the place with various different meanings, depending on what you're reading. So
Yeah, it's very true. I'm just finishing
yeah.
up a project and I'm writing a paper and I'm thinking now even of my use of the term mechanisms because you see behavioral mechanisms, you see
Mhm.
process oriented mechanisms. There's a lot of synonyms now, so I appreciate you kind of helping us distill it down to the most important part. So looking at the most important part based on obviously the evidence that you sourced, what mechanisms should we be aware of with regard to applying manual therapy and what we potentially think is kind of happening under the skin?
Absolutely. So I think first and foremost, I kind of outlined what we did because I think it's important to understand why we chose the route we did for this large review we did. a lot of the groundwork has been set on this by, Joel Bialofsky did a lot of the groundwork on this in some of his work on manual therapy. Carol Courtney did some beautiful groundwork on, what some of the mechanisms are. So we kind of understood some of the things that are occurring. And based on the fact that they've been studied for a number of years, they've gone through a lot of clinical trials. And there's actually been a lot of reviews that have already been done looking at different aspects of this. What are the neurovascular stuff that occurs? What are the neuroimmune things that occur? So there's a lot out there. So we decided to do a kind of a modified umbrella review, a review of review. Now, typically an umbrella review just looks at systematic reviews. It says it's a review of systematic reviews. We wanted to be more inclusive than that. We wanted to include scoping reviews. We wanted to include narrative reviews because we really wanted to cast a broad net and say, what are all of these things happening within these organisms when you apply manual therapy to them? So we did this large review, which was published in March 2025 in PLOS One. Since it's been published, it's actually been cited 63 times already, which is pretty awesome because it means people are reading this stuff. It means people are interested in it, which, to me is great because that means people are interested in figuring out the why behind how manual therapy works. It it included all types of manual therapy that were external to the body. So looking at manipulation, mobilization, soft tissue mobilization, so thrust and non-thrust manipulation, soft tissue techniques. We did not include needling because we knew, once you break the skin, it kind of includes a different aspect of things. So we're actually repeating this review currently with needling. So hopefully those results will be interesting as well. But right now, this is just looking at other manual therapy techniques. And what we did is we incorporated studies that looked at living models. And so this could be animals or humans, but they had to be living. And the reason for that is we know these systems are interactive. So me pushing on, cells in a petri dish isn't going to tell me what's happening in the system as much as a living human model that's able to tell me how some of these things are working together. And so with that, we came up with these different domains of results for what we found, and we kind of categorized them based on where they fell in different systems in the body. And so the first one, and then what we did is we also rated the quality of the systematic reviews to kind of get an idea of how good the literature is in this area as well, these reviews. And so within the neurological domain, okay, which was one of the ones we looked at, what are the neurological responses that happen when we put our hands on patients when we use these techniques? We found 23 reviews. These were of critically low to moderate quality, so they kind of ranged a various, range of quality. What we found is we found increased pain pressure threshold after mobilization and manipulation. We found changes in cortical and subcortical activity through things like functional MRI, EEG, different measures of those activity. We found improved condition pain modulation, and we found reduced temporal summation, okay, within the neurological domain. Within the neurovascular domain, there was actually 32 reviews which looked at some type of neurovascular response. Okay. Again, critically low to moderate quality. So kind of a range there with these, but nothing really high quality. We saw research that showed this sympathoexcitation as well as sympathoinhibition. So it wasn't really consistent one direction or another with that, but we saw some changes there kind of supporting sympathetic system inhibition or excitation. We found increased skin conductance and then variable heart rate and blood pressure responses, some showing a raise in those things, some showing a decrease in those things, depending on the study. The next area we looked at is neuroendocrine mechanisms, which is less studied there. 12 reviews, which were critically low to low quality, which looked at things like changes in cortisol level. Again, we saw some showing an increase in cortisol level with manual therapy techniques, some showing a decrease with cortisol levels with manual therapy techniques. One of the other ones that was a little bit less studied was looking at neuroimmune responses. So what is the response of the neuroimmune system? Now we know this is in the new big sexy thing in pain, right? Everyone's saying the neuroimmune system has is a huge player here. Also in manual therapy, we're seeing that there's a lot of kind of research and a lot of interest in this area. And what we found is overall there was 12 reviews of critically low to low quality. And overall, we saw an increase in anti-inflammatory cytokines and a decrease in pro-inflammatory cytokines. So kind of favoring, pushing in that opposite direction that we see in a lot of people with chronic pain, trying to correct some of those things out. Neurotransmitter and neuropeptide changes were shown across 16 reviews, critically low to moderate quality. Changes in things like increase in things like oxytocin, changes in beta endorphin, mixed findings for substance P, and then little changes in epinephrine and norepinephrine, which is kind of interesting because a lot of people think that's one of the things we're changing with some of these hand-on techniques, and we just didn't see that in the literature. And the neuromuscular changes, looking at things like, EMGs and things along those lines, across 16 reviews, we found critically low to low quality to say that there's reduced EMG activity in compensatory muscles, improved muscle recruitment within the muscles that are supposed to be doing the activity, and then changes in muscle spindle discharge. So it basically got those muscles working in a more, quote unquote, correct pattern, after manual therapy techniques. And then lastly, the good old biomechanical changes, right? The one that we thought drove all of the clinical response was we found 14 reviews, all of which were critically low quality. Okay. And so it was kind of interesting. There were some that showed changes in joint position, very small, altered soft tissue properties, changes in muscles, things like that. And then some changes in disc diffusion, changes in disc, material and whatnot. And so it was interesting because, this area that we've kind of harnessed as this must be the reason it's working was actually the area that had the least amount of support out of all of these things. So when you ask me, which of these we should be focusing on, which of these we should be harnessing or really emphasizing with our patients, all of them, but also none of them, because we're not really sure which ones are the important ones, right? And so that's one of the challenges with this. And one of the things we really had to paint with our in our discussion for this paper was just because these things happen doesn't mean it's consistent from patient to patient. We know contextual factors will influence this from patient to patient. B, it's likely not consistent from different techniques. We lumped these all together, but there might be some differences between thrust and non-thrust manipulation, and things along those lines. And C, because these things happen, we have to be very careful not to assume that they lead to some clinical change. Again, I use that example of, realigning the spine, but also, those neuroimmune changes. I mean, these are something in the beginning of COVID, there was a large consensus paper that was published in the chiropractic community that basically said we have to stop saying we're treating viral infections because, yes, we were able to see these changes in tissue. We're able to see neuroimmune changes, but that doesn't mean you're changing this, viral load in a patient. Right? Doesn't mean you're seeing changes in this clinical outcome. And most of these studies did not look at translation to clinical outcomes. So long story short, we don't know which of these actually matter or if any of these matter at all.
Mm. It's a great overview. I think there's a ton of information there for people to digest. What I found most interesting as I read your paper and I look at that image that's in the paper is, as you kind of eloquently mentioned, the least amount of evidence is kind of under the biomechanical mechanisms umbrella, so to speak. Which is interesting. I'd love to get your feedback on this because when we think of manual therapy in general, we tend to kind of put it in the biomechanical category. But you're kind of saying, well, based on the research, we maybe should put it in the neuroimmune vascular category, which, may cause us as clinicians, educators, researchers to think, well, not only what's really happening here, but how do we discuss this with our patients, or how do we frame this as with our patients as far as, what this treatment's doing?
Yeah, absolutely. And I think it's challenging because most patients understand manual therapies is it must be fixing some biomechanical thing.
Yeah.
And so it's challenging because again, the research doesn't say that this isn't a reason that we're getting patients better, right? It's just saying that there's a lot of other stuff also involved. So this in isolation is meant. Just as in pain, we can say pathoanatomical stuff can still cause pain, but it's not the whole piece, not the whole puzzle. It's one piece of that more complex picture. So I think it's important to, to emphasize that these things might still be important. We're not really sure yet. Okay, we don't want to totally throw them to the wayside and say these things just totally don't matter. But I think it changes our perception of how we apply manual therapy techniques to say, okay, maybe I don't need to focus on, this one specific segment and closing it. Maybe if I just start, moving this stuff in this area, I'll see how this system, the whole system responds and then kind of go from there. With patients, it's also very challenging because you don't want to nocebo them, right? If a patient comes in to my clinic, I mean, I'm still primarily a clinician. If a patient comes into my clinic and they say, I just need you to pop my back into place. I just need you to push this vertebrae back into place. It happened. Somebody did it a couple of years ago. My back's been great for 3 years since. The last thing I want to do is totally nocebo this patient. But at the same time, I don't want to feed into this false kind of rhetoric with this, right? And so it's a challenging thing. And I think, part of that therapeutic alliance process is understanding when to have those conversations with patients and how. Sometimes it's just little kind of wording to start getting things to understand this. Yeah, we can get this tissue in this area to try to get it to move a little bit better again. But a lot of times it's all of this stuff moving together. It's not so much one vertebrae out of place. If the image did, it probably wouldn't show anything popped out that we need to pop back in. That's not a thing, right? And so, validating them, you definitely want to validate the patient's concerns and validate, what they're saying, but at the same time, kind of starting to push that needle away from that. And I think that's a critical thing we need to do. Something else I think is important for us to realize is this isn't unique to manual therapy. Guess what they're finding with stretching? And pain, right? They're finding with stretching and pain, when we're applying stretching techniques in pain, us stretching the tissue isn't really what makes the patient better. Same thing with the whole tendonitis debacle and tendon changes, right? We're saying, yes, tendon changes can occur, but these don't correlate with changes in pain. So all of these treatments we provide, it's not just manual therapy, all of these treatments we're providing, we're kind of taking a step back and saying we looked at everything from fixing a pathoanatomical thing, and now we're realizing I don't think much of what we do is actually that strengthening. We're not really seeing true changes in the muscle, but guess what? Patients feel better, right? Patients are able to activate a muscle better, even though it looks exactly the same, right? So the structural stuff, the pathoanatomical stuff is becoming, less of the whole puzzle and just more of just one very small piece of it as we understand all of these other domains and how much they're involved.
Yeah. When I look at this body of work too, it also makes me think that it's helping bring manual therapy back into chronic pain care, so to speak. Because I think for a moment in time when the realization that pain was a problem of the nervous system, so to speak, we took out manual therapy just for the reasons you're saying. But now looking at what you're saying and knowing that there are all these neuroimmune neurotransmitters and other mechanisms, it may, depending on obviously, the decision of the clinician and obviously with the patient, but it may have a clear place in chronic pain management per se, if it's working on the nervous system.
Absolutely. And, it depends on the patient, right? It's not right for every single patient, as in, other treatments, right? It's based on the patient in front of you. It needs to be applied in a very person centered way. But there's a reason that manual therapies are in so many clinical practice guidelines, right? When the World Health Organization's clinical practice guidelines came out, there's this big fuss of, oh, they have spinal manipulation in there. Why? Because it works, right? Because a lot of studies show it's very effective. And so, it's we know these manual therapy techniques work. It's not a matter of whether they work, it's a matter of why they work. And again, as all of these other techniques are kind of showing, no one is saying, okay, well, if stretching isn't really stretching the tissue, but patients are getting better, then we need to throw away stretching, right? No one's saying that. They're saying, okay, well, you should still do it. Just appreciate it's not doing what you thought it was. But for some reason, manual therapy is put under this lens, and people say, well, if it's not realigning these things, if you're not moving this tissue, just throw it away. But you're absolutely correct. It should be incorporated in a lot of care plans. It looks a little different, right, than what we thought it was 10 or 15 years ago. But should it still be incorporated in a lot of our care plans? Absolutely. Based on that patient specifically sitting in front of you, it's a very good tool to have for a certain patient population.
Yeah. How do we get clinicians to appreciate all the different mechanisms that are kind of happening here, um, to try to move this information forward? Because I think it's important information. Because once you see really what's happening on a neurophysiologic level, it really changes your view of manual therapy.
Absolutely. I think it's challenging because if you think about manual therapy, it's there's multiple different professions that use it that all come from very different kind of theological and philosophical backgrounds, right? You have osteopaths, you have chiropractors, you have physical therapists, you have occupational therapists, you have soft tissue practitioners, or massage therapists, right? And they all come from different training backgrounds. And physical therapy was right there with all the other professions, thinking we were doing very biomechanical things, right? Thinking we were changing these structural things. And so it's challenging because people have been treating patients based on these philosophies for years, and they've been getting positive response, right? They got a lot of patients better. It's not saying that techniques don't work if you think you're realigning things versus if you think you're, modulating the neuroimmune system, right? But it's simply a fact of, at a certain point, we're lying to patients, and at a certain point, there's kind of this ethical dilemma of if a patient thinks that there's this physical change that I'm fixing and they need an external person to fix, is it going to be something that causes some degree of reliance? Now, the literature doesn't support manual therapy leads to reliance, but that's kind of the one of the concerns related to creating this biomechanical, I'm going to realign you like you go your car aligned, kind of mentality. And so, I think from a training standpoint, we have to do, we really have to push the literature. And, the National Institute has done a great job. I'm a co-investigator on a U24 grant called ForceStat. And, what we've done, essentially, this NIH grant is made to push this information out there to better understand force-based manipulations or manual therapies. And so with that, we've done a lot of literature in this area. We've done a lot of research kind of seeing what's out there, where are the gaps in this area, where does the research need to lead? We're really trying to push some of this information out there. But at the end of the day, there's going to be some individuals that just aren't having it. There's going to be some individuals that are just kind of so deep in their school of thought that they don't want to change. I have an interesting story on that actually. I trained for one of the VA's pain programs for that interdisciplinary pain team programs. It's called the ADEPT program, and it was interesting because we did a training earlier this year, and we had a manual therapist there. And as we're talking within these groups, and talking about why individuals have chronic pain and why chronic pain exists. This individual who serves on a pain team said chronic pain exists because sometimes it takes patients too long to get their misalignment of their spine diagnosed. And until they're able to see somebody who's able to diagnose and fix that misalignment of their spine, it's going to continue to get worse. Now, there's theologies, there's philosophies that think that way.
Yep.
That believe that chronic pain exists because of these things. And so, it's challenging because some of these people, they've trained their whole life that way. They've trained under these ideas that this has to be the cause of everything, and so you're not going to change these things overnight. I think, the best we can do is slowly push the needle in that direction, try to get some of this information out there, try to get people to better understand what is and isn't happening. And then, hopefully as the research kind of paints a clearer picture, we can have more concrete answers for that.
Yeah, it's interesting how our belief systems run so deep. I can think back to school what I learned about, or I was told how manual therapy worked. I'm sure some of those are still with me on some level, and I think it's just part of what we do as clinicians, right? We kind of re-update or update those beliefs as we take continuing education and read papers like yours, and hopefully access evidence. Where are you going in the future with this work? Obviously, it's a manual therapy is a, as you mentioned, it's a big field. Where are you kind of taking this forward?
So as I mentioned previously, we want to do a large review like this for needling techniques, so acupuncture and dry needling. We're currently in the process of that. It is going to be a massive review. It's going to end up being larger than this one. I don't know why we undertook it. I mean, it's gonna be a fun project. It's nice to map out some of these things because they've dealt with a similar conundrum, right? Where it's oh, I'm changing this, I'm doing this. Well, no, you're not, but maybe it's this. And so trying to fill some of these pieces together. So that's one of the projects we're working on. We're also looking at trying to develop a lot of work that outlines what research in this area should look like. Because a lot of folks, they have the patients in front of them, and they have even the data, but they're not doing the right type of analysis to really figure out, is this something that causes a clinical outcome? Unless they do that mediation analysis or look at that translational value, they can say, yes, this occurs, and yes, the patient got better. But unless you tie those two together through the right statistics, we don't know if that's actually why they got better, right? And so we're looking at some things, some publications trying to outline what different mediation analysis, what different study designs should look like. We're looking at possibly developing a reporting guidelines for manual therapy mechanistic study that can kind of outline hey, this is what you should report, this is what you should be doing, so that we can really put together quality evidence. Because again, you look at the evidence we found, and it's critically low to low quality for a lot of these, a couple moderate quality. That's no good. I mean, that's telling us, yeah, these things happen, but there's a lot of stuff we don't know. There's a lot of stuff that hasn't been, that picture that has been painted clearly. And I think, what we need to start putting out better literature in those areas, high quality literature in those areas, for us to kind of know where to go moving forward.
Yeah, and with that, I'd imagine we're still developing tools and methods to measure what's actually happening with manual therapy.
Absolutely. Absolutely. Yeah. The mechanistic measures are really interesting. And we used to have to, look at brain, function through EEG and some of these wired things. Now they have some of this, functional near infrared spectrometry and some of these wearable EEGs that look like a winter cap that these people put on, and they can go about their day and do things. And we have, trackers that people are able to put on their finger or their wrist to measure their heart rate and all of these things. We have the opportunity to get a good picture of what these people look like, what's going on in their brain and their cortical, subcortical processes, what's going on in their bodies, outside of that snapshot that we see in the clinic. So yeah, there's a huge opportunity here to, better understand what's happening in people when these techniques or any other, interventions are applied.
Yeah, great stuff. I'll definitely be looking forward to the one on dry needling and acupuncture. I know those are areas people are always interested in. Again, diverse schools of thought on how those two interventions work. Again, I point all of you to +1 2025, The Mechanisms of Manual Therapy, a living review of systematic narrative and scoping review that Damien wrote. I want to thank Damien for joining us this week on the podcast. Please let our listeners and viewers know how they can learn more about you and reach out to you if you have any questions.
Yeah, I think you can look me up on social media. I'm not highly active on there because social media is interesting these days. But you can always look me up on social media, or contact me through my information that's on any of my publications as the corresponding author for any of those. I love hearing from people. I love hearing about collaborations and ideas people have. And Joe, thank you for having me. I mean, it's been wonderful talking to you. So thank you.
Thanks so much, Damien. Of course, please make sure to share this episode with your colleagues, anyone who's interested in the mechanisms or the science behind how manual therapy works in health, well-being, and of course, pain care. Thanks so much, Damien. And thank you all. We'll see you next week.
Thank you for listening to the Pain Science Education Podcast. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's integrativepainscienceinstitute.com. Sign up to receive weekly updates and learn about our continuing education courses. If you enjoyed this episode, leave us a review on your favorite podcast platform and share this episode with your friends. Please join us next week as we share more science-backed solutions for treating and reversing chronic and persistent pain.